All right, so I believe we're live now. Thank you all for being here with us today for this third Center for Pharmacy Practice Innovation Facebook Live event. Living under pressure, we're going to be talking about high blood pressure today, which is also known as hypertension, and our panelists will go into that a little more. But before we get started, I just want to introduce our moderator to you all real quickly. Art Espy is here with us today. He's going to be talking with the panelists, asking the questions. He is the managing director of Paladin Global Services, which is a strategic advisory and media management company. But kind of more pertinent to this conversation, he is a husband, dad, and entrepreneur, and author who takes high blood pressure medication every day. He believes that knowledge empowers you to thrive, particularly when it comes to living with chronic conditions. And so he's excited to moderate this panel and help you move forward toward living happily ever after while managing high blood pressure. So that is all from me, and I'll let you take it away, Art.
Thank you, Madeline. Hello, everyone, and welcome to our educational panel here on managing your high blood pressure through the proper pharmaceutical impacts. So we've got a wonderful panel here today, and let's let them introduce themselves. And Dave, if you want to start with the introductions, then we'll go on down the line.
Sounds great. Thanks so much, Art. So my name is Dave Dixon. I am a pharmacist by training. I am a faculty member at the VCU School of Pharmacy here in Richmond. And in my practice, I work alongside cardiologists to help the providers and patients manage their medications to improve cardiovascular conditions like high blood pressure. I also do research evaluating how pharmacists can help improve high blood pressure outcomes, as well as how we can improve the quality of blood pressure measurements. And I'm happy to be here.
Evan?
Great, thanks, Art. My name is Evan Sisson, and I'm also a pharmacist. I'm a professor at VCU School of Pharmacy. Prior to coming to VCU, I was worked at the VA Medical Center in Richmond in an interprofessional diabetes and lipid clinic. My current practice, though, is at a free clinic here in Richmond that cares for patients without health insurance. And the Center for Healthy Hearts focuses on chronic diseases like diabetes and high blood pressure. And in making that transition from the VA to the free clinics has opened up a whole new world for me, helping patients try to navigate how to not only take care of their health, but do it in a way that's low cost and effective. And so I'm glad to be here today and share some of our experiences.
Excellent. Good afternoon, Lana.
Hi, Art.
Hi.
Hi, everyone. I'm Lana Sargent. I'm assistant faculty at the School of Nursing. I'm dual certified in family and geriatrics, and I carry a clinical practice right now in geriatrics at VCU, but I've had 17 years of clinical experience, primarily in community-based settings. So my focus is really taking care of people who don't have access to care. That's always been my primary focus. And then my research is really focused on aging syndromes, cognition and physical frailty, which we know cardiovascular diseases are usually predecessors for those conditions. And I'm excited to be here with you all today, so I can bring the aging perspective to things.
Excellent. Salvatore?
Yes, good afternoon, everyone. It's really a pleasure to be here. My name is Salvatore Carbone, and I'm an assistant professor in the Department of Kinesiology and Health Sciences here at VCU, and I have an affiliate appointment with the VCU Poly Heart Center. I'm a dietitian by training, so today I will be talking about nutrition, and I try to answer all the questions you have about diet and nutrition. And clinically, I work in a multidisciplinary clinic with pharmacists, in this case, Dr. Dixon, and cardiologist, physician at VCU. And I do, a lot of my time is actually dedicated to research, taking care of patients that have obesity, heart failure, which often have hypertension, so high blood pressure. And then I dedicate part of my time to teaching undergraduate students here at VCU.
Excellent, excellent. So as everyone can see, we've got a wonderful panel to go into what high blood pressure is. So let's start with that very basic question of what is high blood pressure and how is it related to hypertension?
Well, Art, I think I'll kick things off. You know, when I think about blood pressure, the image, the analogy that comes to mind as we're heading into the summer here in Richmond is watering the lawn. And, you know, if you have a flexible hose and you want to water your lawn and keep it from turning brown, you need a sufficient amount of water going through the hose that the hose stays open and gets water to all the grass in your yard. Too little water, your grass turns brown and dies. Too much water, it's possible that hose will bust or the connection at the spigot will leak and break. And so the same kind of thing happens in our body. And so as our bloodstream is delivering oxygen and nutrients to all the tissues and cells in our body that need those things, there needs to be enough pressure that the blood and oxygen can get to where it needs to go, but not too much that it actually causes damage, just like too much pressure in the hose.
Excellent, excellent. Thank you. Can you talk a little bit about what high blood pressure or hypertension, some people don't understand the difference or the sameness of high blood pressure and hypertension. Are they the same or are they different?
Dave, you want to lead off on this one?
Sure, happy to. So it's very true that our blood pressure fluctuates throughout the day based on our activity and what we're doing. So a single elevated blood pressure, we kind of refer to that as being a high blood pressure. The difference between that and what we call hypertension is when someone develops hypertension, they have a chronically elevated blood pressure that is sustained over most of the day, and in some cases even while we sleep, the blood pressure may stay elevated. And it's really that chronic elevation of blood pressure that we really are mostly focused on in terms of using our lifestyle and medication therapy interventions to treat that. If we go and we exercise, our blood pressure increases, right? If we're stressed out, our blood pressure increases. But certainly in individuals where that increase occurs most of the time and that blood pressure stays elevated most of the time, that's really what we're mostly focused on when we say or use the term hypertension.
Thank you for identifying the difference between those two terms, the differences there. So what can high blood pressure lead to? What are some of the things that it can cause?
Yeah, so high blood pressure, well, we'll start at the other extreme. I think everybody is familiar what happens when you don't have good blood flow to an area. All you have to do is cross your legs for an extended period of time, and then your feet fall asleep, right? Basically, you've cut off the blood supply to those nerves. The nerves don't have the oxygen nutrients they need, so they go to sleep. So once you uncross your legs, you restore blood flow to that area, the nerves wake up and all is good. So the same kind of thing happens, on a chronic basis, that if nerves and cells aren't getting the blood supply that they need, they could die. But if the blood is pumping through your system at too high of a pressure, it can cause damage. And so for very small blood vessels in the back of the eye or in the kidney or even in the brain. If the pressure gets too high, then those blood vessels could burst, and then everything downstream, that all those cells that needed a good transit of blood supply aren't going to get what they need, that it's going to be an interruption. And so there's going to be cell death. So strokes, loss of vision, kidney damage can be caused by high blood pressure, but that's in the little tiny blood vessels in our body. Even the larger blood vessels in our body can be affected by high blood pressure, especially if it's in combination with high cholesterol. And so that's where we think about high blood pressure contributing to heart attacks and strokes. So there's a narrow operating range that we're designed to operate in. And so the goal is to not have the pressure too low, but also not have it too high either.
Is high blood pressure genetic?
So certainly we do see that high blood pressure tends to run in families. And so there is definitely a genetic component. It's also true, though, that families often share similar environments where they work, live, and play. And so it can, in some cases, be challenging to separate the two. But generally speaking, high blood pressure is definitely something that we observe as being common among family members. And there's other factors to consider when we think about how, why is high blood pressure so common? And one of those certainly relates to, our kind of Western diet, right? So kind of high saturated fats, high salt intake. 1 in 2 American adults are either overweight or obese, and 1 in 10 adults have diabetes. And so the rise in the prevalence of these conditions is at least a major contributing factor to why we continue to see high blood pressure be so common in the population. And in fact, over 100 million Americans have high blood pressure. So it's certainly something that we see on a regular basis, and most people they know someone in their family that has high blood pressure.
Wow, 100 million. That's just shy of a third of the population, isn't it? The U.S. population. Wow. So, Lana, you're our expert on age, on people aging. Around what age do you see where it's common for people to start being concerned, or should they be concerned about chronic high blood pressure or hypertension?
When I think about that, I think it's something that is a lifelong lifespan process, right? That we should be talking to people about, like Dr. Dixon said, their environment, what they're eating, their, what they could do to keep their cardiovascular risk down all the way. Now, when you get to my stage, so once you're walking through our door, above 60, we see different things. We see now the complications related to that hypertension, at which point we see both the structural and functional changes related to hypertension. So we have to watch for other things, like Dr. Sisson said about just blood pressure in general. When we get to 60 and older, at that point, we still want to talk about prevention, but we're really talking about management and trying to manage the blood pressure as best we can to keep within those target goals that Dr. Dixon mentioned, to prevent a lot of the end organ damage that happens, the renal and the cognition factors. We also in older adults need to be thinking about the structural changes that happen just with aging that change the blood pressure. So with older adults, we can get the arterial stiffening that happens. So when you check that blood pressure, it doesn't recoil. And so when, in that case, sometimes with older adults, we see this isolated, elevated systolic, that top number, be elevated. And so there's different things that we think about as people get old, not only how long they've had it, but just the fact that then now there are structural changes within their anatomy that present differently. But I would say we talk about it all the way from the very beginning. It should be a conversation, you know, diet and healthy lifestyle should be a conversation that we have in school age, in the schools, because you don't want to get to the point where you're seeing me really with it. At that point, we're talking about managing multiple chronic diseases all at once.
Wow. So what are some of the common signs that that somebody should typically start being aware of if they think they might have high blood pressure or hypertension? What are?
I would say everyone can add in here too, but headache
yes,
is a
please.
common, headache's a common one. You know, for our patients, we see dizziness, headache. Sometimes it's silent. Some patients feel nothing for periods of time. Or, you know, we start to catch it at other visits, not their primary care visits. They go to the dentist and get their blood pressure checked there, or they happen to go to the pharmacy, right, and get their blood pressure checked there and noted that it's elevated. So they may not feel anything at all, but I would say the things that we see are most common, or at least the top list that we see, is headache, dizziness, certainly, hopefully I'm not getting to the point of having shortness of breath where it's, you know, it's really high, but those are the two most common ones I see. Does anybody else see anything else?
Yeah, Lana, you mentioned patients going to see their dentist and the dentist checking the blood pressure and realizing, wait a minute, your blood pressure is really high. And then the dentist will say, I'm sorry, I can't work with you today because your blood pressure is too high, because the dentists are concerned that a bleed in the gums might happen and then they can't stop it. But the patient walked in to their dentist thinking, hey, I'm fine. I don't feel any differently. And I think that's the really almost scary part about high blood pressure and hypertension, is that there is a gradual onset over time, a gradual rise over time, and people just don't realize the difference. It's not sudden all at once.
Do I recall years ago that wasn't high blood pressure called a silent killer or something of that nature in some of the media? I remember some type of media campaign or something, educational campaign that referred to it as that.
Yeah.
So Evan, could you elaborate a little bit on some of the different stages of hypertension and high blood pressure?
Sure. So I mentioned earlier, you know, my mental image when I'm thinking about blood pressure is that flexible hose out in the yard. And there's a certain pressure that of the fluid going through that hose that keeps that hose open. In us, that's the bottom number when you get your blood pressure checked. That's the diastolic pressure. That just keeps that hose open. As the heart is pushing blood, pumping blood through all of our arteries, of course, when the heart squeezes and pushes a big supply of blood through, the pressure is going to go up. The blood vessel is going to try to expand, and it's going to reach a certain point where it can't expand anymore. And so then that's the top number, the systolic pressure. So we're going to, when you get your blood pressure checked, we're going to measure it typically on the upper arm, seated, back supported, feet flat on the floor. The cuff should be on the bare arm, and you should sit there for about 5 minutes. And what we would expect to see is that for somebody with a normal blood pressure, quote unquote, the numbers should be less than 120 over 80. That's what we think is a normal blood pressure for all of us as humans. An elevated blood pressure is between 120 to 129 on the top number when the heart is squeezing and pushing blood through. But we would expect that bottom number, the amount of fluid just keeping the blood vessels open, to be still less than 80. Now, hypertension is when the blood pressure is above 130/80. And then there's different staging that you might hear about. But when the blood pressure is above 130/80, that's when somebody would be diagnosed with hypertension, that chronic elevation that Dave talked about earlier.
Okay, so that's hypertension, but there's a condition of pre-hypertension, and could you just elaborate? Just take a moment to differentiate between those two, just for our audience to be clear on that.
Yeah, if we say that normal is less than 120/80, so the top number is less than 120, the bottom number is less than 80, and we say that hypertension is above 130/80, so there's that middle ground where people don't meet the criteria for hypertension, but it appears like they're on their way. And as Lana pointed out, and even Dave, our diets are sort of setting us up, genetics aside, our diet is setting us up for elevated blood pressures. And so it's something that's very important, even when somebody is in childhood, to learn good eating behaviors, nutrition, good healthy lifestyle, to make sure that later on the blood pressure doesn't rise as people get older.
Excellent, excellent. And I think, thank you for that, Evan. I think that's a great segue into our next question, which is really some of the best interventions or some of the best things that people can do in order to address these challenges at the pre-hypertension level and avoid it from becoming full-on hypertension or chronic high blood pressure. Dave, you want to talk a little bit about that?
Sure. So, in terms of really trying to implement some lifestyle or non-medication type of interventions, one of the biggest things that we can do is to reduce our body weight. Of all the things that we have at least some influence on, if we're able to lose weight, that's going to result in the greatest reduction in blood pressure. And in fact, a 5 to 10 pound weight loss can reduce the blood pressure by as much as 10 points. So it can certainly have a significant effect. Exercise, of course, is a significant component of that, and just kind of overall heart health. Another thing that could really have a big impact is giving up smoking. So cigarette smoking, certainly associated with a higher risk of developing hypertension. And that's really one of the first things that we look at and assess is, does this individual smoke? And if so, then working with them to get them to quit smoking is a top priority. And I'd love for Salvatore, to get his perspective on, what's an optimal dietary or nutritional type of intervention that patients could utilize. What's some advice that they could use to kind of help reduce their blood pressure?
Yes, thanks, Dave. I think diet really is one of the most important piece of the puzzle to prevent hypertension in the first place, and even to prevent pre-hypertension. Really, we often talk about treating a disease and treating a risk factor, but we don't prevent it enough. So I think we've been stressing this concept today quite a few times, but it's important to remember to address that when we don't have it. So let's try to prevent the risk factor in the first place, which we call primordial prevention. While we tend to focus too much on the risk factor once they're developed, but once you have it, we have to work with it. And so from a dietary perspective, there's a number of things that really we can do to improve the blood pressure significantly. And in addition to losing weight, which that can be achieved either with exercise, but also with cutting calories from your diet. In someone who has overweight or obesity, we typically ask to reduce their calories by about 400 to 500 calories per day, which allows to induce a decent weight loss throughout their dietary intervention, I would say. But specifically from a nutritional diet quality, so the quality of the food that we eat, because not all the patients that have hypertension or pre-hypertension need to lose weight, right? We have many who have a normal weight, but still they have a high blood pressure. And so particularly in those, it's very important to control several nutrients, but two are particularly important for blood pressure control. And one is sodium. That is the major component of salt, the typical, the salt that we have in our kitchen. It's composed of sodium and chloride, but sodium is really the bad part of salt. And so that is what we should control in our diet. And to give you an idea, in the United States, on average, we eat about 3 to 4 grams of sodium, which is almost 2 teaspoons of salt per day. And the dietary guidelines suggest that we should eat less than 1 teaspoon a day. So we eat really almost double the recommendation of sodium that we are supposed to be eating. And actually the American Heart Association suggests that we should cut that even more. So the amount of sodium should be even like almost half a teaspoon a day. So it's really low amount of salt that we should have in our diet. So salt, or sodium, I should say, not good for blood pressure. More sodium we eat, the more the blood pressure goes up. And so we should try to cut that as much as possible. And what are the major sources of sodium? A lot of people think that sodium only comes from salt. In reality, the major source of sodium in the United States in a typical American diet is from sandwiches. So most of the sodium comes from about 30% of the sodium comes from sandwiches. And many of us think that actually sandwiches can be healthy, but not necessarily. Like in this case, they can be rich in sodium, and that could be a major contributor to high blood pressure. But also when any food really contains sodium. So one thing that I think is very important for all of us, for those who are listening today, is to learning how to monitor sodium intake. How do I even know how much sodium I'm eating, right? We say, oh, eat less sodium. And so sodium, fortunately, is one of those nutrients that is listed in the nutrition fact of all foods. It's a requirement from the FDA really to have sodium amount in the label. And so as a number, we should target to have a diet that contains less than 2,300 milligrams of sodium per day. The AHA, the American Heart Association, suggests that actually we should eat less than 1,500 milligrams of sodium per day. So extremely low amount of sodium. And typically, that can be measured by just having sort of a food diary every day. And for a few days, not every day, you can really write down every time you eat something, how much sodium you're eating, and then check that at the end of the day. You can also use apps to monitor the amount of sodium that you're eating. And so sodium, definitely not a good food not a good nutrient for hypertension or pre-hypertension. But we have another nutrient that actually does the opposite. And that is potassium. Potassium, it's really a very strong, it's a nutrient, but it actually works as a medicine to reduce blood pressure. And so increasing potassium intake, it's actually associated with lower blood pressure. And what are the foods that are very rich in potassium? These are typically fruits and vegetables. These are the major sources of potassium in our diet. And in fact, the diet that we should follow for blood pressure control is called DASH diet, or dietary approaches to stop hypertension, which emphasizes the consumption of fruits and vegetables because of the high content of potassium and extremely low content of sodium. Potassium can be found also in other foods. For instance, salmon, avocados are food that are very healthy because they contain a lot of healthy fat, but also they have very high amount of potassium and very low amount of sodium. So there is a number of food that we can eat in our diet to increase the amount of potassium and to reduce the amount of sodium really as much as possible. And just the last point on the sodium piece is that even if you have a normal blood pressure, sodium intake should be controlled and reduced as much as possible, because there is a strong evidence to suggest that even if your blood pressure is controlled, sodium intake is associated with a higher risk for cardiovascular disease because it makes your your vessels stiffer, and so increases your risk to have cardiovascular disease.
Thank you for that, Salvatore. That was very good. So the key takeaways, everyone, are taking a lot of sodium in and not exercising and sweating it out, not a good lifestyle. So with that being said, even if you do some of those things or you don't do any of those things and you end up having hypertension or chronic high blood pressure, you guys are pharmacists, let's talk a little bit about some of the medications that are available to manage it, the types of them, kind of how they work, in very, very layman's terms, so everybody can understand. It's been a long time since I was in biochem.
Well, you know, Salvatore, I think, you know, gave a lot of good advice from the dietary standpoint, and I'd just like to underscore that's the foundation of the treatment and therapeutic approach when we're working with people with high blood pressure and hypertension. But for some folks, even with the best interventions and best diet and best exercise program, they still can't get their blood pressure down. And fortunately, there are a lot of medication options. You know, I think because there are so many options, it can be overwhelming to patients and providers. And one of the things I like to think about is Yogi Berra said, begin with the end in mind, right? And so, because if you don't know where you're going, you probably won't get there. So if what we're trying to do by lowering blood pressures is to avoid heart attacks and strokes and blindness and kidney damage, what are those medicines that have shown that blood pressure lowering medicines that not only lower blood pressure, but also help prevent heart attacks and strokes and help kidney function? It turns out that there are four kind of groups of medicines that fit that bill. One is the calcium channel blockers, which there are calcium channels that help regulate the tone of arteries, blood vessels. And that would include medicines like amlodipine or nifedipine. Another group of medicines are the ACE inhibitors, which these are all the pril medicines, enalapril and lisinopril and benazepril, fosinapril. A similar group of medicines are the angiotensin receptor blockers, or the ARBs. These are the TANs. These are the losartan and valsartan and irbesartan. And then finally, there are the thiazide diuretics, which include hydrochlorothiazide, chlorthalidone, indapamide. These are four groups of medicines that, as somebody who has attempted a good, healthy lifestyle, but still has elevated blood pressure, that we're going to start to add these medicines on, oftentimes in combination, because they're working in different ways. Dave, you want to talk a little bit about how these medicines work?
Yeah, sure. So, you know, to put it simply, there's really a couple different approaches to lower blood pressure with medication. And this, you know, really does vary based on the individual. In some instances, you know, one of the contributing factors to the high blood pressure may be a rapid heartbeat. And so we might use medication to slow down the heart rate. In some cases, it may be due to the fact that the blood vessels are maybe too stiff. And this is a part of the normal aging process, like Lana discussed a moment ago. You know, as we all age, our arteries become a little less compliant, a little less flexible. If we have other medical conditions, that process may happen even sooner. If we have high cholesterol, that process may develop a little bit sooner. And so one of the ways that our blood pressure medications can work is to help relax the blood vessels, to decrease that pressure and allow that blood to flow through the tube or like Evan mentioned earlier, through the water hose more easily to reach its destination. And kind of another kind of third general way that the medications work is if we have too much volume, you know, if our salt intake is really high, you know, sometimes you might notice that, you know, your feet or your lower legs may be a little puffy, or you may feel even a little bloated. And that's because water and sodium are best friends. And so if your diet is very high in sodium or salts, you're going to retain more water. And so we could use medications to help remove some of that excess water and reduce the kind of excess volume that can also result in a lower blood pressure. And then I thought Evan made a great point about the fact that, you know, unfortunately, we don't have a single blood pressure medication that is kind of the best, so to speak. And most patients, at least 2/3 of patients with high blood pressure will require at least 2 medications in addition to lifestyle change to get their blood pressure under control. And so, you know, if your provider is wanting to add more medication, that's not uncommon. And so I think it's important just to kind of, you know, to keep that in the back of your mind when you're, you know, working with your medical provider to manage your high blood pressure. That's not uncommon. We have to do that quite a bit to get it under control.
Thank you, Dave. That and Evan, that really addressed some questions that I personally had. Could you talk a little bit about, as an extension of those points, could you talk a little bit about some of the side effects of the common medications and how to kind of manage those side effects, particularly if you're on 2 medicines and have never been on medicines before?
Sure. So, you know, any medication that we take, you know, does carry a certain degree of a risk of side effects. And, you know, blood pressure medications in general can, you know, it can take some time to adjust to what we would consider to be a more normal blood pressure. So, you know, some dizziness or lightheadedness, you know, can occur in general when we treat blood pressure. As far as some of the specific side effects, so with any of our medications that are going to help remove extra volume, like I was speaking about earlier, such as some of our diuretics, it can mean an extra trip or two to the bathroom to urinate, to kind of get rid of some of that extra volume. We also have to monitor certain electrolytes, such as potassium. Some of our blood pressure medications, like the diuretics, force out a little extra potassium in the urine, while some medications, such as the Prial drugs, the ACE inhibitors that Evan mentioned, and the sartan drugs, the ARBs, like losartan, can actually increase our potassium. And so monitoring the potassium is important. And that's why we often use a diuretic with one of those 2 drugs in hopes that we get a kind of balancing effect on the potassium. And the 2 drugs actually work well together to help lower the blood pressure quite effectively. One of the other classes, the calcium channel blockers, amlodipine is a frequently used drug in that class, is generally well tolerated and does a nice job of relaxing the blood vessels so that blood can flow more easily. But in some patients, what that can do is cause a little bit of leakage of that volume from the blood vessels in some of the kind of surrounding tissues in the lower legs. And some patients will have some swelling of the feet with amlodipine. We can address that, and certain combinations of blood pressure medications can reduce the chances that that happens. So, again, all medications have some side effects that we have to look for. But again, by and large, blood pressure medications are well tolerated overall. One other thing I did want to mention with the pril drugs, such as lisinopril, some patients can develop a dry cough. It's not a cough that is going to be permanent or hurt you. But if you stay on the medication, this kind of nagging dry cough can be quite annoying. And so if that happens, typically we'll switch you over to a different medication that's not associated with that cough. And then very rarely, but it does happen, the lisinopril or pril type of drugs, a patient may have an allergic reaction to that particular drug class. We call that angioedema. And that can result in swelling of the tongue, and sometimes it can involve the throat. And it is a serious side effect. It is rare, however, but it is one that we kind of look out for. And if a patient develops that side effect, then there are certain blood pressure medications that we permanently avoid in that patient. But the good news is we have a lot of options in terms of medications for blood pressure. So, there are still other options to help you control your blood pressure.
Excellent. Thank you for that. Lana, you work with a lot of people who have multiple chronic conditions. And so I'm sure there's lots of conversations on drug interactions and things of that nature in that community. Could you just briefly touch on that?
Absolutely. I was thinking about everything that has been said, that we do take a careful approach to starting medicines and taking medicines away. So for starting medicine, since we know that it may take more than one medicine to get to a target goal, because they do work differently, we usually start a medicine and then follow closely, right? So we're looking for those side effects. We're monitoring blood work as we're going along to make sure people are tolerating. And then we'll add on a second medicine only after we know the person is tolerating until we get to target goal. Now, if people are already taking those medicines, it is possible that we have to adjust things. We do that, we take that same process again. We will remove one medicine at a time, and often sometimes medications come in combination. Maybe they're on already one pill, but there's two medicines in there. We're very careful, even when that happens, about pulling those medicines off by removing only one of those components, right? And keeping them on the other one, so that we're careful about knowing what we're taking away one at a time. And following typically very closely, meaning every 2 weeks, so that we can monitor a lot of what Dave said. So, how is the effect of the medicine? Are we still getting a good effect while not causing a side effect at the same time, or while we're also monitoring blood work?
Thank you for that wonderful explanation, Lana. That was very helpful, particularly for like an adult child that might be helping their parent kind of manage this whole process. So thank you for that explanation. That was very helpful. So let's move on and talk a little bit about the lifestyle and we've got a few minutes left here, folks. So let's talk a little bit about lifestyle and what kind of changes we can make in our overall lifestyle. We've touched on it a little bit, but let's bring it all together. If you're diagnosed with hypertension and now you've got to manage it, or if you're managing a parent, what are some of the general lifestyle changes that somebody needs to make?
I can take this one.
Yeah,
And really, many of the lifestyle changes that we discussed just a few minutes ago for the pre-hypertension or elevated blood pressure are similar to what we should follow in those who actually have a diagnosis of hypertension. And so really reducing sodium intake, increasing potassium intake when possible through diet, possibly, but supplements can be used as well after discussing that with your provider. Really, a healthy diet or a heart-healthy diet, it's a diet that is rich in fruits and vegetables, which also contains a high amount of fibers, which are well known to also have a blood pressure lowering effect, which can be found in whole grains. Really, more recently, we have data also to support the concept that a Mediterranean diet, so a diet that is typical of the Mediterranean countries, rich in healthy fat, like, for instance, olive oil or other food like avocado. They have this fat, which people sometimes are scared of eating fatty food. But in this case, we're talking about healthy fat, which has been shown to have some blood pressure lowering effect. And also, I would say, let's not forget that patients with hypertension often have a lot of other different conditions, comorbidities. And so this dietary pattern, which could be a little bit of a DASH diet, Mediterranean diet, really are helpful to treat and prevent coronary heart disease and improve cholesterol in the blood. So these are really things that we should do even if we don't have hypertension. Sure, when we have hypertension, we need to be more careful and possibly monitoring some of these nutrients like sodium and potassium intake even more. But this is something that all of us can do, really. We should do in our, to prevent high blood pressure in the first place. And then one other point I wanted to make is that, as Lana was mentioning, Dave and Evan, to be monitored by a healthcare provider from the pharmacology perspective, I think it's also really important to be followed by a trained dietitian for the nutritional perspective. Because often we do have patients who said, oh, I was on a diet and it didn't work. But sometimes that might not have been exactly the right diet for that person. And maybe there were some mistakes that they didn't know they were making. So my recommendation is always, before saying that your diet is not working, is to be followed by a professional, so a dietitian. They can really help you in finding the right diet and tailor the diet based on your habits, based on your culture, based on your what you typically your habits throughout the day. So that's a point I wanted to make. So, and of course, the last really 30 seconds is to, like Dave has mentioned earlier, exercise remain crucial. Exercise, independent of the effect of weight loss, can reduce blood pressure dramatically. And it's not just aerobic exercise. Some resistance training, you can go at the gym or you can do at home, that also has been shown to reduce blood pressure.
Okay, excellent. What about yoga? Has that been shown to help people reduce blood pressure?
Yeah, really any kind of physical activity that has been shown to reduce your blood pressure. I cannot think of one study or one exercise that is associated with burning calories and yet not improving blood pressure. So I would say yoga will likely improve blood pressure to some degree. But each one of us is different. So we all respond different to therapies, to different diet, exercise. And so you might need yoga or you might need something else. So that's why I think it's important to talk to a healthcare provider that can really tailor the intervention based on your needs.
Yeah, and just to add to that, I would say certainly chronic stress, right, is certainly a driver of elevated blood pressure, and especially this past year, we've all been stressed beyond the norm. So exercises or activities such as yoga and even Tai Chi and some of the other kind of meditative type of activities have been shown to improve blood pressure, through helping individuals better manage stress and get learn some skills in terms of helping to manage stress. So, I think for most of us, that can be of some value.
Excellent. Thank you for adding that there. Salvatore, one quick question. There's a question one of our listeners asked about fish oil and olive oil and how that impacts the lowering of high blood pressure or impacts blood pressure at all. Could you address that?
Sure,
briefly,
yes.
Please?
Mm-hmm. Yeah, so the evidence related to fish oil in terms of blood pressure reduction, it's not very strong. So I would not say that fish oil improves blood pressure similar to a medication or other dietary strategies. But it does have it does improve blood pressure by a little, by 1 or 2 points but for the olive oil, it's actually very different. A lot of studies are showing dramatic benefit on blood pressure in those who are consuming a large amount of olive oil every day. And actually the component that's been shown to affect blood pressure in basic science data is the oleic acid, which is a particular fat that can be found in olive oil, but can be found also in canola oil, avocado, can be found in nuts, mixed nuts. So those are all food that have been consistently associated with a significant reduction in blood pressure in very well conducted studies.
So Salvatore, let's quantify and break down that large amount. Is that a tablespoon a day, or am I chugging it like I'm an undergrad?
I would say a tablespoon per meal.
Okay.
Yeah. So we're talking about most of the studies have done at least 3 to 4 tablespoons per day.
Okay.
When we talk about olive oil. When we talk about other foods like nuts, for instance, we talk about a handful of nuts. And remember, when we talk about nuts, we're talking about the unsalted or lightly salted nuts.
Yes.
Because the salted nuts actually have a very high amount of sodium. So then we're fixing one thing and ruining it, another one. So we need to be careful about that. I had a question about sodas. Since they're highly consumed in the United States, and both regular sodas and diet sodas, they do have quite a good amount of sodium. And so even if the diet soda don't really have the sugar, and so we're cutting calories, they do have sodium in it. So we need to be careful, especially if we have hypertension. But I would say if your diet is really perfect and you're really able to achieve that, to meet the sodium requirement, and then if you want to add a diet soda and you're still below that recommendation, that is okay. But that's something, again, I would strongly encourage you to discuss with your pharmacist, with your dietitian or your primary care.
Okay. Could we just, as we're getting ready to wrap up, could we just briefly talk a little bit, maybe Lana, on about weight loss as far as lifestyle changes go?
Sure. Do you mean specifically about kind of what to do, or?
Actually, just some of the things that we may not have covered between diet and exercise, specifically for weight loss. We know that weight has a big impact on people's blood pressure, and just, is there anything that
we've been covering? I was going to say we've been covering a lot of the really great things. I think Salvatore covered a lot of great ground with dietary intake. I think more and more we have to be cognizant of what's put into our food and being aware of what's on the labels. And so I think he makes a great point of having a dietitian as part of your team, right? And access to someone to help with that. Moving every day. Now we have lots of great technology that pushes us to move, watches, our phones, anything really. And I think Dave also made a great point that certainly two things have been impacted by this past year, not only our stress and our emotional, but potentially also our physical movement. In this past year, where we've been told to, stay at home, or we're working from home more. So movement and exercise, I think, can mean a lot of things. So to really expand your mind on what that can mean, if that's just getting up every 15 minutes to move around your house. I have lots of patients who just say they get up and walk around or go to the mall sometimes in the wintertime, or if they don't have a safe place around their home to walk, they go to someplace like a mall and walk around. Even getting up and walking around your home to different rooms, can be helpful. So thinking creatively about making sure you keep those things in your life all the way through your lifespan.
Yeah, and just to add on to what Lana was saying, moving is important. And just to quantify it, the recommendation for a general healthy lifestyle would be 30 minutes a day, about 5 days a week. So a total of 150 minutes in a week's time would be a goal that everyone should seek.
And Evan, just to touch on this point, I think it's crucial that the newer guidelines American guidelines for physical activity that were released, I think maybe a couple of years ago, they really changed the way we count minutes. So in the past, you could only count physical activity that you were doing for at least 10 minutes. If you were doing less than 10 minutes, that wouldn't count within your 150 minutes. But now really any movement counts. So even if you're able to do those 2 minutes of physical activity, that counts into your weekly 150 minutes that you mentioned. So sometimes you see patients that they say, oh, I don't have enough time. But actually, if you even do those 5 minutes of walk, that will help. So that's important.
Every little bit helps. So yes. Salvatore, that's a great point. Let's talk. So we've talked about these wonderful lifestyle changes, but what guidance would you give somebody that says, wow, that's a challenge for me to make those changes in my life, or for me to help my parent or loved one that I'm helping manage their health conditions, their chronic conditions, to make in their life? Do you have any last words of guidance to help people who are working hard to make things work every day and struggling to make that happen? Any last words of wisdom on that?
Well, I think I'll start off and I'll let other people add in. But we're talking about lifestyle change. So we're not talking about what just a one and done kind of thing, but what are some things that need to be done to change the trajectory of someone's life that has high blood pressure? And so for the better. And so I think what I always recommend is pick one thing. Don't pick 10 things. Pick one thing that you can do today, and then repeat it tomorrow. And then when it becomes a habit, pick something else. And so thinking about it, in a very incremental way, 6 months from now, a year from now, the health will be greatly improved.
Thank you.
I think that's a great suggestion. And, I would add to that, a lot of people find a lot of value in buddying up, find someone else that can push and motivate you. I think that's incredibly helpful. And nowadays, that can be done through a lot of different apps. And there's different apps out there for tracking, helping you track your exercise and your diet. So MyFitnessPal is an app that I really like because it's free. There is a premium user edition, but for what most of us would need it for, it is free. And just about any food from any restaurant or grocery store that you can think of is actually listed in there. So it can really help you keep track of things. You can have friends, again, building that kind of make it competitive in some cases. Setting rewards for yourself, once you reach certain goals. Most of us have a competitive spirit somewhere in there, and taking advantage of that, I think, goes a long way to helping change behaviors.
Thank you, Dave. Lana, any last words?
Well, I would just stress what was said before about picking especially if someone feels like it's too daunting to make a change about many of the things that we've been talking about, is to pick something small. It doesn't have to be big, just one step, and then make it manageable. You know, if you say you're going to do it every day, is that really possible? Is it really okay to just do it once or twice a week? Yes, it's okay. It's a start. So sometimes we think, you know, we have to make these really big changes and we have to make them all at once. But I agree, sometimes it can just be that one small step.
If I can add just one last point, I think it's important for the healthcare provider for sure, but particularly for those who are at home, to monitor their progress over time. And now you can really buy a scale, a blood pressure cuff, of a very low price, even a pedometer. You can buy now like a Fitbit-like watch for $10, $15. That's really important, because if you really notice that you're not seeing a change in those parameters, that's probably a sign that you need to talk with someone to do something. Don't wait a year or 6 months, but try to address that. If you don't see a change in a month or two, that's probably there's something that's not working. So I think all of us should keep monitoring all the risk factors at home when we can, of course.
Thank you, Salvatore. And thank you for everyone on our panel for answering some of these wonderful questions about high blood pressure and hypertension, and really making it easier to understand some of the challenges that 100 million people in this nation face. So thank you so much. Madeline?
Yes, thank you all for this great information. I think our audience has really benefited from it. And thank you to the audience for joining us today. We appreciate your time. And if you have any other questions, feel free to comment on our page. The experts here at the Center for Pharmacy Practice Innovation are happy to help where we can. So with that, thank you all and have a great rest of your day.
Thanks.